sensitive on the back.
Hello and welcome to another live broadcast with MedStar Health. This month we're celebrating Heart Month by raising awareness of heart-related conditions. I'm Sarah Ridenour, and today's topic is an essential one for all of us: heart failure. Heart failure is a common cardiac diagnosis and one of the leading causes of hospitalization. Fortunately, there are treatment options available, but successful treatment depends on understanding risk factors, recognizing symptoms, and getting timely treatment. Through this discussion, we will provide valuable insight into how heart failure is diagnosed, the stages of heart failure, and the treatment options available. So give us a like to let us know you're watching and share this broadcast with your friends and family. This condition affects millions of people worldwide, so help us spread the word. Before we get into our discussion, let's meet our experts. We have Dr. Jennifer Brown, who's an advanced heart failure cardiologist, Dr. Farouk Sheikh, who is also an advanced heart failure cardiologist, and Dr. Tania Vora, who's another advanced heart failure cardiologist. Thank you all for joining us today. We appreciate you taking the time out of your day to answer our questions. So let's get into those. First of all, Dr. Sheikh, what does heart failure mean?
Sarah, thank you so much for the invitation, and I'm very excited to be joined by my esteemed colleagues, Dr. Vora and Dr. Brown. Heart failure is a term, a phrase that refers to a disease state or a syndrome where the heart is incapable of keeping up with the activities necessary for daily living. Another way to think about this is that the heart is a pump. It's a muscle and it's a pump, and it's in the state of heart failure, the heart is no longer able to pump properly. We broadly speak of this disease state, which affects nearly 7 million Americans, as two categories: those where the pumping function of the heart is reduced, which I know Dr. Vora will be answering in greater detail with the next question, where we refer to as heart failure with reduced ejection fraction. And that is roughly half of the nearly 7 million Americans who have it. This is juxtaposed to heart failure with preserved ejection fraction, where seemingly the heart's pumping function seems intact, but the ability of the heart to receive blood or function in its normal parameters is abnormal. When we think about what happens in this disease and the suffering that patients and their families go through, patients develop breathlessness, fatigue, they can have swelling, and they're incapable of doing their activities of daily living. It's highly treatable, and though the phrase heart failure does not sound very optimistic, as we hope to articulate over the next hour, it's actually highly treatable. There's a lot of reason to be optimistic. There are wonderful treatment options. I think it's never been a brighter time for the treatment of the disease.
Thank you. That's great to hear. And Dr. Vora, can you explain ejection fraction and the role it plays in heart failure?
Sure. Thank you for having me here as well. So ejection fraction is a measurement that we most often obtain from an echocardiogram, which is an ultrasound of the heart. It essentially tells us how well or what percentage of the blood the heart is able to pump forward with every contraction or every heartbeat. It's a very important measurement in heart failure. As Dr. Sheikh was saying, it helps us to categorize people and classify their heart failure. So the patients who have heart failure with preserved ejection fraction, meaning that their ejection fraction is normal, but they have other mechanisms to give them heart failure with the relaxation of the muscle. And then there are patients who have heart failure with reduced ejection fraction. And it really is important to make the distinction, because based on which category you fall under, that's going to help us determine which treatments you're going to be eligible for and benefit from.
Thank you. And let's talk a little bit about the causes and risk factors, warning signs, all that. Dr. Vora, what causes heart failure?
So heart failure is a really large umbrella term. There's lots of different causes. And so when someone does come in with heart failure, we kind of think through a differential in our heads of what the potential causes can be. One of the most common causes of heart failure is actually ischemic heart disease or blockages in the heart. So we oftentimes will do an evaluation to look for any blockages or something we can fix. It can also be caused by metabolic syndromes or patients who have obesity, diabetes, can be at higher risk of developing heart failure. It can be related to substance use. Alcohol, excessive alcohol use can also lead to heart failure. There's also other disease processes like HIV. There's infiltrative diseases, which are actually diseases that affect the muscles of the heart that can cause heart failure. And then there are certain viruses that can also do it. So there's actually a very large differential diagnosis that we have to think through when we meet a patient or encounter someone with heart failure.
Thank you. And so going along with that, Dr. Brown, what are some of the most common risk factors of heart failure?
Sure. So some of the most common risk factors will include uncontrolled high blood pressure, coronary artery disease or blockages in the heart arteries, diabetes, particularly if it's uncontrolled, obesity and metabolic syndrome, and certainly family history. So it's really important that we take a full history. And if patients have siblings or parents that have died at a young age from either heart failure or sudden cardiac death, then we certainly think of familial cardiomyopathy as a possibility.
Okay. And are there gender differences in risk factors or prevalence of heart disease?
Sure. So not as much as you would expect. Actually, we often talk about the gender differences in presentation of coronary disease. It's known that men and women have different symptoms when it comes to heart attacks. But when it comes to heart failure, men have a slightly increased incidence, but the overall prevalence of heart failure is similar between men and women. Women tend to have more diastolic dysfunction, meaning heart failure with a preserved ejection fraction or a strong heart. And women also tend to be diagnosed at a later stage. And so when we meet women with heart failure, they are often farther along their disease process.
Okay. And what are the warning signs or symptoms of heart failure? And I'll lump that in with my next question, which is at what point should someone see a physician for a diagnosis?
Sure. So some of the warning signs are going to be increasing shortness of breath with exertion or decreased exercise tolerance. So feeling like you used to be able to walk, up and down a flight of stairs, no problem, but now you find you have to stop midway. New swelling in the ankles can be due to heart failure. There are other causes as well, but certainly signs of edema. Or rapid weight gain. So if you see your weight go up by 3 pounds in a day or 5 pounds in a week, and you haven't changed your diet and you're noticing swelling, that can all be due to excess fluid that the body is holding on to from heart failure. Feelings like you can't lie flat in bed. Some people will say when they lie flat, they feel like they have to cough or they have trouble breathing, and that's due to fluid in the lungs. And often they find that propping themselves up on multiple pillows will help relieve those symptoms. And fatigue in general, just feeling like just can't go about the day-to-day activities that they used to do. So that would say, going on then when you should see a physician. When you're having any of those symptoms, absolutely any of them, it's important to see a physician. That physician can start as your primary care doctor for sure, as there are other causes of shortness of breath and fatigue, but any of those symptoms deserve a formal workup by a physician.
Good to know. Thank you. Dr. Sheikh, how do physicians diagnose heart failure?
Thank you, Sarah. Heart failure is diagnosed by multiple interventions or strategies. The most important is being with your doctor and your doctor performing a thorough physical examination to look for signs and symptoms. This includes a history. So our physicians and clinicians, APPs or advanced practice providers, nurse practitioners, physician assistants will ask patients about their history, their family history, risk factors that were highlighted very nicely and articulated by Dr. Vora and Dr. Brown, and then actually a review of the symptoms that may be existing. They will perform a physical exam, which in concert with or in collaboration with ultrasound of the heart, known as an echocardiogram, this imaging tool, is central to making that diagnosis. Additionally, laboratory testing is needed. So laboratory testing allows for a biochemical assessment for the presence of heart failure. So there's a way to make that diagnosis with blood testing as well. But I think the take-home message here is we need multiple tools in our toolbox to make the diagnosis. Nothing will ever supplant the time spent with a clinician and the patient together to learn about the patient's symptoms. That is the most central aspect of this evaluation.
Thank you. And we mentioned earlier that there's different stages of heart failure. Can you explain those stages a little bit?
Yeah, very happy to. Just like any field, the field of heart failure, and that we've been very thoughtful in our field, thinking about the language of the words we use. We're instead of using heart failure, many of us are now using function, not failure. Again, to remind people to be optimistic. This is treatable. Yes, it's important. It's a serious illness, just like cancer is a serious illness. But as we've learned in cancer and through the nomenclature of cancer, we've learned that if we can stage the disease, we can get the word out to the community about the importance of thinking about this cardiovascular disease, which we recognize is increasing in its prevalence, to be able to really structure treatment strategies. And so the American College of Cardiology and the American Heart Association, two leading organizations in the United States, a number of years ago developed a staging strategy. And those are stages A through D. Stage A are those individuals at lifetime risk for heart failure. I'm actually one of those people. I have a family history of coronary artery disease. So that means, and I have a family history of high blood pressure. So those are two risk factors that place myself, now in my 40s, at the risk for heart failure sometime in my life. And that means that of the greater than 350 million Americans that live in the United States and seek care, they need to recognize, and we need to recognize, that millions and millions of us are at risk for development of heart failure in our lifetime. And the choices we make in our lifestyle, seeing our doctors and addressing issues like diabetes and high blood pressure can have a profound impact on the prevention of heart failure. That's number one. So that's stage A. Stage B, B as in boy, are those individuals who have structural problems with their heart, but they're asymptomatic. They're living their life, they don't know it. And this is a group of individuals that are also, again, larger than the 7 million Americans that I mentioned who have actual symptoms related to heart failure. It's a much larger group. And this is why seeing your primary care physician, seeing some clinician may help identify if you're at risk for that. The way in which we find this many times amongst our group is there'll be screening studies done. College athletes or high school athletes will be encouraged to go get an EKG or an electrocardiogram or echocardiogram, and then they're asymptomatic, and sadly somebody identifies a weak heart, and then they now have stage B heart failure. The reason why I'm perseverating on this is highly treatable. With wonderful medical treatments, we can take individuals who might have a problem with their heart muscle that they didn't know about and actually normalize their cardiac performance, preventing symptomatic forms of the disease. Stage C heart failure is the largest group that we're referring to today, which is the group that are those individuals who are symptomatic. There's roughly 7 million Americans I mentioned. That number is growing because we, until the COVID pandemic, survival was improving in the United States overall for all individuals. We've had a little bit of a setback in the pandemic, and hopefully that will improve over time. But that means people are living longer, and if you live longer, that means the chances you will develop heart failure in your lifetime increases. And so that number, as we approach the year 2030, will increase to nearly 8 million Americans. This again, very nicely discussed by Dr. Vora, means we have to really characterize what type of disease or form of disease do you have? Is it heart failure with reduced ejection fraction or preserved ejection fraction? Do you have a family history that might make us want to do genetic testing? Are there other illnesses that you might have that might suggest that your heart is an innocent bystander, but it's been affected by another process in your body, such as rheumatologic diseases, lupus, and other inflammatory diseases, which might put you at risk? And this is where comprehensive assessment is required. And then a smaller group of individuals, stage D patients, otherwise known as advanced heart failure patients. Those individuals, despite medical treatment, which has been optimized, unfortunately suffered with daily symptoms that are affecting their quality of life and their ability to function. Those things include the ability to just shower normally, or go to work normally, or even walk a block. This group of people, which is estimated to be about 5 to 10% of that 7 million that we estimated, are those individuals where we have to think beyond medical treatments. And there are surgical treatments that can improve survival. Those include cardiac transplantation and then left ventricular assist device therapy, otherwise known as LVAD therapy, which as a group we are expert on.
Thank you so much. That was a lot of different stages to explain, but you did a great job at simplifying it for us. So thank you for that. Before we get into talking about treatments and managing heart failure, we have a couple questions from our viewers that I wanted to ask. Our first one is from Michelle, and she asks, what is the normal ejection fraction rate? Dr. Bora, I know you talked about that earlier, ejection fraction rates earlier. So can you answer that question for us?
Yes. So a normal EF or ejection fraction is 55 to 60%.
Okay, great. Thank you. And our other question is from Anita. How related to high blood pressure is heart failure? If BP is being controlled with meds, but it's still over 130 over 70, then how much is a patient at risk?
Sarah, who would you like us to answer that? Who would you like?
Oh, whoever wants to.
I'm happy to jump in on that one. So undoubtedly, uncontrolled hypertension is a very important cause of heart failure, and making sure that your blood pressure is well controlled, less than 130 over 80, is paramount to preventing heart failure down the road. If your blood pressure is well controlled on medicine, the risk of developing heart failure is much less, particularly if you are controlling other illnesses and risk factors such as diabetes, coronary disease, and obesity. So the old mantra is know your numbers, and it certainly holds true here. So we want to make sure that our blood pressure is well controlled, that our weight is well controlled, and that we're doing everything to reduce the risk of developing things like diabetes and coronary disease.
Great, thank you. Another question from Michelle. Once you are diagnosed with heart failure, will you always have it? I know we've talked about how it's treatable, but is it, I guess, curable, or will you always have it?
I'll tackle that question. It's a really important one. And again, this gets back to the linguistics or the language we use, because we understand that in the suffering that all of our patients feel, getting labeled is never easy. And with it carries a burden, the idea of I have heart failure. I think it's reasonable to say that what we've learned about the disease is that we always want our patients who have experienced heart failure or symptoms of heart failure, have been diagnosed with it, to ensure that all clinicians, all of their physicians and other clinicians are aware of that diagnosis. It is true, it's highly treatable. Patients who have signs and symptoms of heart failure, we can improve them, make them asymptomatic, recover their ejection fraction. But the reality is that they will be lifelong at risk for recurrence of the disease, and it requires regular touch points with clinicians. So being mindful of it is important. We recognize the burden that label places on people. We're sensitive to it. In fact, many of us are moving away from using the phrase heart failure. But that being said, it is important because it's not a disease state that we can just forget about. Meaning, we're very lucky. All of us have enjoyed. In fact, I was looking at data for one of my patients today, whose ejection fraction has normalized 3 months after the treatment for heart failure with reduced ejection fraction. And what I will state to that individual is that we need to see each other regularly. We have to keep close contact. We have to continue taking our medications, living a good lifestyle, exercising regularly, reducing our stress, and having regular touch points so as to make sure that there isn't any slide back towards a more symptomatic version of the disease.
Great, thank you. And thank you for all of your questions. We have more, but we'll get to those in a minute. We're gonna go into our treatment questions first. Dr. Bora, what are the common medicines used to treat heart failure and how do they work?
So the first thing in terms of medications, so there are medications that we use for symptom management. Oftentimes people have symptoms that you've heard about with the shortness of breath and fluid buildup with swelling in the legs because they have too much volume. And so many common medications are diuretics. So things like Lasix, furosemide, Bumex are common medications. Beyond symptoms, though, it's a good time to be in heart failure because we have a lot of good medical therapy. So especially for the patients who have heart failure with reduced ejection fraction, we like to tackle this with quadruple therapy. So there's 4 classes of medications that we like to get on board. One of those classes I won't bore everybody with all the mechanistic details, but the first class are beta blockers. So things like metoprolol or carvedilol that you may have heard about. The second class are your ACE inhibitors, ARBs and ARNIs. Entresto is really the gold star of this class. Losartan, lisinopril are other medications that are in this class of medications. And then the third one are your mineralocorticoid receptor antagonists like spironolactone and eplerenone. And then the fourth one we're really excited about are the SGLT2 inhibitors like Jardiance and Farxiga. These medications actually help with both reduced ejection fraction and preserved ejection fraction. But essentially, with heart failure with reduced ejection fraction, we feel like we've come to a place now with science, and we know that there's a lot of pathways that in the body essentially go awry and cause maladaptive remodeling of the heart. So all these medications together work on the neurohormonal system of the body, and they help the heart essentially get better, get stronger, and ultimately lead to the patient feeling better, decrease heart failure symptoms, and actually improving mortality and morbidity. So they're really good medications that we have now that can help to treat heart failure.
So that we have a viewer question that relates to this. Diane asks, I proved to be allergic to Entresto and spironolactone. Is there another medicine that can be prescribed? It sounds like yes, she should just maybe talk with her doctor about it and decide what would be best for her.
Yes, there are other medications we can try.
Great, thank you. And thank you, Diane, for your question. Dr. Vora, do lifestyle modifications make a difference? And maybe, would that be along with medicine or on their own? Can you talk about that a little bit?
Absolutely. So I think, especially with heart failure with reduced ejection fraction, I don't want to undermine the importance of these medications. If we can get them on, they're really important. They do help. But lifestyle modifications are also very important. Studies have shown exercise daily, if you can work your way up to doing 30 to 60 minutes of cardiovascular exercise 5 days a week. It's a big goal. You start slow and kind of work your way up. That is going to improve your prognosis. It's going to improve how you feel, quality of life, and you will do better with the same disease state. So exercise is very important. And then management of the other risk factors in terms of getting your blood pressure down. If you have diabetes, treating diabetes with the diet part is really important. Avoiding toxic substances like tobacco, minimizing alcohol, all of these things do help improve the cardiac function and improve symptoms and survival with heart failure. So absolutely, lifestyle modifications do matter.
Great, thank you. Dr. Brown, can both internal medicine physicians and cardiologists treat heart failure?
Absolutely. Our primary care doctors are really our first line in our care, and it's very important to see them, particularly when you're developing these symptoms. Because as I mentioned, there are multiple causes of shortness of breath and fatigue. And so we need the primary care doctor to investigate not only the heart, but other causes like anemia, for example. But once a diagnosis of heart failure has been made, I think it's really important that every patient with heart failure have a cardiologist. The reason for this is as we've mentioned, it's a really exciting time right now for heart failure, both heart failure with reduced ejection fraction, as well as for heart failure with preserved ejection fraction, because there are new therapies that are coming out, and there are nuances in the imaging studies that we ordered. Dr. Sheikh mentioned an echocardiogram, which is an ultrasound of the heart. There are things that we can see in the ultrasound of the heart that might lead us to understand the etiology of one's heart failure and then order more testing. And it's not to say that the internal medicine doctors can't do this, but they are not trained to read the echocardiograms. And so they are therefore reliant on an outside person reading that echo. And I think in medicine in general, regardless the field, you always want the provider taking care of you to be the one who's looking at the imaging. A picture is worth 1,000 words. And so you really need a dedicated cardiologist to review that echocardiogram as well as the other testing that's been done, the stress test, the EKG, or maybe they've been referred for cardiac MRI or other imaging, to put together the diagnosis to make sure all of the avenues have been evaluated and all of the etiologies pursued, because as we've mentioned, it's a really exciting time. We have new treatments for multiple forms of heart failure that are making people feel better and live longer.
And then when does someone need to see an advanced heart failure cardiologist? Are they recommended? Is that something that they can, just schedule an appointment with one of you, or how does that work?
That's a great question. Unfortunately, there are far more heart failure patients in this country than there are advanced heart failure specialists who can take care of them. That being said, there are some warning signs that the heart failure is progressing. And at that point, seeking out an advanced heart failure specialist is really important. So some of those warning signs include hospitalization. So if you've been hospitalized for heart failure twice in the last year, for example, that's a sign that your disease is progressing and you should seek out an advanced heart failure specialist. If you are being told that you have end organ dysfunction, so what I mean by that is that your laboratory data is showing signs of kidney damage or liver damage. These are signs that the heart failure could be progressing and affecting the organs. And that's another reason to see an advanced heart failure specialist. If your blood pressure is low and your doctor is having to back off your heart failure medicines, that's another sign that heart failure is progressing and you should seek expert care from an advanced heart failure specialist. Additionally, if you have a defibrillator and it's been shocking you for bad heart rhythms like ventricular arrhythmias, that too is a sign to seek an advanced heart failure specialist. And if you have symptoms at rest. So if your symptoms used to be well managed, maybe you used to be able to do those regular walks 20 minutes a day, but now you've got to the point where you really have symptoms almost at rest or with minimal exertion, these are signs that it's time to seek out advanced heart failure expert care.
Thank you for explaining that. Dr. Vora, how often do patients need to see their physician to make sure their heart failure is under control?
So it does depend on how you're feeling. I think in the beginning, it would be better to see your physician more often, especially if you're having symptoms. And when you're first diagnosed with heart failure, there's a lot of testing that we have to do. So we may have you come in once a month, or depending on your symptoms, even more frequently. But once the symptoms are under reasonable control and patients are on steady medications, I think coming in every 3 months is reasonable. I think it's really important if any symptom comes back that you reach out to your doctor's office to be seen more quickly, so that if things do need to be adjusted with the medications, we can do that soon. But I think every 3 months, once we're in a stable state, is a good goal.
Okay. And so kind of going along with that, Dr. Sheikh, what are the indications that treatment modifications are needed for patients?
Sarah, thank you so much. Before tackling the question, just expanding on the wonderful comments by Dr. Brown and Dr. Vora, I wanted to make 2 points. I mean, one of the reasons we're here today is we want to do the following: empower patients with knowledge so they themselves can determine the best plan ahead. The key part of that is making sure that patients and those that are joining us, family members for individuals who suffer from heart failure, really have a detailed discussion with their clinicians to understand what are the treatments I'm on, what's the disease I have, and identifying potentially gaps that might exist, which would then empower patients to make sure they're getting the right treatment. There are wonderful resources online: the American Heart Association, the American College of Cardiology, the Heart Failure Society of America. I encourage everybody to pursue them. It's incumbent upon you to do it. And I would reiterate, that we are facing a challenge, that there is a shortage of heart failure certified or board eligible cardiologists that can take care of this disease, but that should not be a limitation. Just as with other diseases, I made the analogy to cancer, and I said that in the best possible way, because we hear the word cancer and we think, my God, it's terrible. But just let's reflect in 2023, cancer survival has never been better. And why is that? Because there's a system in place where individuals that get the diagnosis of cancer see experts who are capable of delivering care. That includes oncologists. And we are on that same journey in the treatment of heart failure. We are available. There's in the MedStar system, in total, I may get this number wrong, but I believe 18 cardiologists across the system that are focused, are either board eligible or board certified, and then countless other cardiologists that are spectacular physicians that can do a great job treating heart failure. And we're available to answer questions and in terms of advocacy. So I want to make sure that's clear. There's a number of tools that patients can have, and the clinicians are excited to help in any way, shape, or form. In terms of the indications for treatment modification, Dr. Brown highlighted symptoms matter. We are working always to improve the quality of life for our patients. So if we are employing treatments to deal with the diagnosis of heart failure, that means that we are expecting that we are going to objectively get the following achieved. Patients are going to be able to walk longer. They're going to be less short of breath. They're going to be less fatigued. And then we're going to do objective testing to determine that we're seeing improvements. That might be a repeat cardiac ultrasound, the echocardiogram that Dr. Brown mentioned. That may be functional testing where we're doing exercise testing to objectively determine that patients are actually improving. Many times we just rely on our patients and their family to tell us, oh, Mr. or Mrs. Smith, just making up arbitrary names, are doing well. But let's put some diagnostic testing into place to make sure that we're actually able to identify that people who you could only walk 50 feet can now walk a mile and do things like that. We have a number of tools, stress testing, 6-minute walk test that can help guide us. And when patients have persistent symptoms, they need treatment modification. We have to re-engage and determine, are we on the right diagnostic pathway? Maybe we're missing something. Maybe we need to use advanced cardiac imaging tools, such as cardiac MRI, positron emission tomography, or PET imaging for select patients. Do we need to actually do invasive procedures to assess the weakness of the heart muscle? That's a procedure such as cardiac catheterization that may guide us. And do we then have to partner with other clinicians across the cardiovascular medicine specialties to think about other diagnoses that could be missed? But the answer is persistent symptoms or lack of response to interventions should prompt treatment modifications or reconsideration.
Great. Thank you for that, Dr. Sheikh. We have a couple more viewer questions that I want to get into. First of all, we have a question from Rhonda. And she asked, how often should we have an echocardiogram after diagnosis of heart failure and enlarged heart? Dr. Brown, I know you mentioned echocardiogram, so can you touch on that?
I sure will. So, that really is a difficult question to answer because it depends patient to patient, but everybody should have an echocardiogram repeated after it is felt that their medical therapy has been optimized. So most of the time we try to achieve that within about a 3-month period from initial diagnosis. And right now I'm really talking about heart failure with reduced ejection fraction or a low ejection fraction. But as we mentioned, there's a lot of medicines and a lot of testing that needs to be done. So sometimes that repeat echocardiogram occurs a little bit later, 4 months or 5 months, if it takes some time to get patients on their optimal treatment plan. But certainly at least needs to be repeated once after the initial diagnosis. And then you'll continue to follow with your cardiologist, hopefully once stabilized, as Dr. Vora said, on average every 3 months. And your cardiologist will then decide if a repeat echocardiogram is needed thereafter. Usually if you have a new physical exam finding, so if, for example, we listen to your heart and we hear a new murmur, that would be a reason why we would repeat an echocardiogram. If, for example, you are no longer responding to your medical treatment, you're continuing to have edema despite up titration or escalation of your diuretics, we might repeat an echocardiogram to see if there's a change in the cardiac structure or if there's been a decline in the function. So I would say that after that initial repeat echo, it's really up to the discretion of your cardiologist based on how you're doing clinically and how your symptoms are.
Okay. And then that question also mentioned enlarged heart. So we have another question about enlarged heart from Gina. Can you explain a little bit more about enlarged heart and enlarged heart? What is it? I guess, just talk about that a little bit more, Dr. Brown.
Sure. So an enlarged heart means exactly what it is, that the heart itself is dilated, meaning enlarging. And it's interesting, patients with a reduced ejection fraction or low EF, the physiologic mechanisms in the body that occur over that period of time cause the heart to enlarge and to dilate. A healthy heart is the shape of a football, and that allows for the best squeeze. But as a heart gets weaker, often the heart changes its shape from a football to more globous, spherical, like a basketball. And this does not allow for efficient pumping of the heart. And so many of the medicines we use help the heart regain its healthy shape which is back to that football shape. So we will often see on the initial echocardiograms at the time of diagnosis that the left ventricle itself is very dilated. And this can cause valvular dysfunction and other issues. And as we optimize the medical regimen, we then see on that repeat echo often that the heart is now no longer as dilated, and those valvular issues have improved because we've maintained the healthy shape that the heart wants to have. I will say, though, there are other reasons for an enlarged heart. So I just want to throw that out there. Enlarged heart does not always equal heart failure. So you may have heard the term an athlete's heart. So we often see with people that are very involved in athletics that they can get thick walls of the heart and their heart can enlarge. The other thing I'll mention is that a chest X-ray often will have in its conclusions that the heart is enlarged. And this sometimes prompts consults to us to do an ultrasound of the heart and look for heart failure and if the heart truly is enlarged. And often the X-ray overreads that. So I think if you are told by your doctor you have an enlarged heart, it's very important that you seek care from a cardiologist and undergo an ultrasound for further evaluation to see if the heart truly is enlarged and if there is congestive heart failure.
Thank you, Dr. Brown, and thank you for your questions. So Dr. Sheikh, on the heart failure spectrum, when is surgery indicated for a heart failure patient?
Thank you so much, Sarah. Our surgical partners are truly our partners. They're intimately related to the care of all of our heart failure patients. And that's because when we talked in the beginning about the optimism we have for the treatment of heart failure, part of it is related to the fact that surgical tools have never been better for the treatment. I'll say surgery sort of broadly because this includes actual structural heart developments. By that I mean tools where we can, with the collaboration with our interventional cardiologists, actually find ways to deliver treatments through procedures where we cross the skin. We call this percutaneous treatments. And so broadly speaking, surgical treatments are actually theoretically possible across the spectrum of disease. By this, I mean stage C and stage D heart failure. Again, broadly speaking, there may be interventions such as replacing a valve of a heart that may be a primary cause of the disease itself, patients developing heart failure symptoms because one of the 4 valves of the heart is not functioning properly. That again requires expert review and discussion. Dr. Brown mentioned this, where the echocardiogram gets a very careful review in collaboration with surgical partners to identify that. It may also, as Dr. Vora was mentioning, as one of the leading risk factors, be where we identify blockages in the arteries of the heart, the coronary arteries, which are so severe as to weaken the heart muscle or cause symptoms of the disease of heart failure, which result in us requiring us to do surgical treatments to reverse that process. Such things such as cardiac bypass surgery is what we're talking about. But then there are those individuals that, despite optimal medical treatment, are still having symptoms where the surgical treatments that many people think of classically in heart failure are twofold. One, cardiac transplantation, which has been, as many know, around for more than 50 years, since the initial cardiac transplantation occurred in South Africa and then subsequently at Stanford University in the United States. And then a more recent development over the past 20 plus years of left ventricular assist device therapy. These are 2 therapies that improve the survival and quality of life of individuals who have an advanced form of heart failure, speaking specifically about individuals who have the stage D heart failure phenotype.
Thank you. And unfortunately, our heart transplant surgeon, Dr. Balsera, is not able to join us today. He's in emergency surgery, but we're going to keep talking about surgical options. So I'll just let whoever wants to take these next couple questions, if you all want to chime in, go ahead. First of all, what is an LVAD and how does it work?
I don't know, Tanya or Jen, do you want to tackle that?
All right.
Sure.
I can go. Okay. So an LVAD is a left ventricular assist device. It's actually a pump that the surgeon puts into the left side of the heart, and it takes over the function. So when it goes there, it actually is continuously spinning. And as it does that, it takes all the blood from the left side of the heart and then they stitch a conduit that goes to the aorta and it delivers it to the aorta. So the aorta is a big blood vessel that supplies blood to the rest of the body. So this machine is actually able to bypass and take over the function of the heart. The catch with it, though, is that it is a battery-powered device and it requires power. So there is a cable that we have to tunnel, not we, but the surgeons tunnel, that goes from the inside and it comes out around the belly button and it's connected to a controller. And so the patient has this controller that's with them all times, and it's connected to batteries that they actually wear. It sounds crazy, but the device is actually really amazing. It helps people feel better, and it's a big lifestyle change that we obviously only consider if somebody is very sick and close to dying, but it can take somebody who can barely walk a block to now go back to work and really resume a normal life. So it's a really great device.
That's awesome. And so you touched on this a little bit, but at what point do people need an LVAD?
I think when you are thinking about heart transplant, or when you're referred to a heart failure cardiologist, and when Dr. Sheikh mentioned some of the other testing that we do to kind of determine when somebody crosses over from that stage C, more stable place in heart failure, to a more scary and dangerous part, honestly, which is stage D heart failure, unless we're able to do something to reverse it. So whenever we're thinking about heart transplant, we have to also think about LVAD as the backup if for whatever reason we can't help a patient get to a transplant soon enough.
I just want to,
oh, sorry.
Sorry, I want to add one aspect. I have no doubt Jen will add something as well. LVAD therapy is entertained, as Dr. Vora mentioned. When we're talking about prognostically, what does the future hold in terms of expected survival from the disease? These treatments are used when, unfortunately, there are individuals, at 5 to 10% of the 7 million individuals we mentioned who have heart failure, where their expected survival based on their symptomatology, objective testing. Dr. Brown mentioned individuals who are recurrently coming to the hospital. They are not expected to live maybe more than 1 year or 2 years. This is where we're thinking about cardiac transplantation and LVAD therapy. And LVAD therapy is a freestanding option for individuals. There are those individuals who will not be, and I know we're going to touch on this hopefully in a minute or two, it may not be at the current status eligible for cardiac transplantation because of other aspects of their lifestyles choices, such as smoking, which unfortunately is an absolute reason why we can't offer transplant, because unfortunately we never want to withhold treatments, but rather we know this lifestyle choice prevents success with treatment. And so LVAD therapy was developed over the past 20 plus years to be a wonderful therapy with excellent 1, 2, and extended survival. We recently in our program celebrated somebody who has been alive 15 years on a heart LVAD, and somebody who's just celebrated 12 years on LVAD therapy. So this is where you want to collaborate with your physicians to really understand what might be the best treatment options for you, given the other diseases that you may be, and other comorbidities you may be facing. Sorry, Jen, let me let you answer any other aspects you wanted to tackle with us.
Well, you guys really have covered it very well. I think you've touched on the point that sometimes we offer LVAD as what we call a bridge to transplant. So that means we're using it as an opportunity until a patient becomes eligible for transplant. Maybe they're a smoker and we need to have them off nicotine for 6 months, or maybe they have another comorbidity like obesity, and we're trying to optimize that to help them be a transplant candidate. For other patients, they're not a candidate for transplant. Probably the most common reason is their age. And so when that happens, then we can offer what we call destination therapy, which means an LVAD as your long-term care. And again, these are really patient-to-patient decisions. There are many, many things that go into when we think about whether a patient is eligible for a transplant or an LVAD. And in most cases, many patients are not eligible for either for various reasons. Perhaps there's uncontrolled diabetes or kidney dysfunction and they're on dialysis. So these are all really complex things that need to be discussed on an individual patient with your advanced heart failure specialist.
So then, speaking of that, Dr. Brown, at what point is heart transplant indicated as a treatment option for a patient?
Yeah, so it's very similar to the reason why you would consider an LVAD. So if you are at the point where you have symptoms at rest, you've been taken off your medications because you can no longer tolerate them, you can't, difficulty staying out of the hospital and controlling symptoms with medications, that's when your advanced heart failure specialist will start to think about a heart transplant. And for many patients, if you are a good candidate, and I will turn that over to my colleagues about what might make one a good candidate. But if you are a good candidate for transplant, often we pursue a transplant evaluation along with an LVAD evaluation at the same time. And certainly heart transplantation is the gold standard of care. And if one is eligible, we will pursue that right away.
Great, thank you. Are there any barriers to heart transplantation?
So the major barriers, I think, have been sort of indirectly discussed. A comprehensive assessment for patients who have advanced heart failure symptoms is performed at centers like ours. You know, the Advanced Heart Failure Program at MedStar Health, which is a regional program. You're seeing actually 3 members of the team that we've highlighted before spread across the DMV. So this is exciting that we can deliver care locally for our patients and families who need our care locally. What we employ is a comprehensive evaluation, which includes assessment by a clinician, laboratory testing, imaging, including CT scans, CAT scans of the body. We have a comprehensive multidisciplinary team that assesses other challenges that individuals may face. You know, the burden of heart function, not failure, is that many individuals psychologically develop depression and anxiety, which, you know, as we know in society is very common, and we are excited that there is no stigma associated with it, rather the exact opposite. We want to help individuals with these highly treatable conditions, which run very commonly with heart failure. You can imagine why. Patients are told they have this disease, they're concerned about their long-term survival, they don't know if they're going to improve. It's an enormous burden for patients and their families. So this multidisciplinary team delivers care across all aspects of the body in a holistic way, so that we're thinking about all of the various parts of our body. And in that evaluation, we try to determine what would be the best treatment for the individual. And, you know, the barriers that might exist include active smoking. You know, unfortunately, the outcomes with cardiac transplantation are not as good for individuals who suffer from more extreme forms of obesity, where their body mass index is above 40. Again, this is on a individual basis. We make the assessment and we always work to identify what's the best treatment. And the key part of that is to really identify what are the goals for the patient, what does the patient and family want to achieve, and whether we can achieve those goals. And so the key part here is to collaborate with the heart failure trained specialist who can help guide you through that journey.
Great, thank you. And Dr. Sheikh, you've all mentioned how this is an exciting time for you guys. Are there any heart failure clinical trials or research studies going on? Can you talk about any, you know, advances in heart failure treatment on the horizon?
There are countless treatment opportunities and clinical trials, Sarah, that have been identified. It's a very exciting time for those who are particularly, you know, in the audience, who are particularly pursuing novel treatments. You know, give credit to the government in this case, clinicaltrials.gov. If you go onto Google or your favorite search engine and identify, just type in clinical trials, there's actually a website dedicated for all individuals, even, you know, individuals without a extensive medical education or background, to look at clinical trials for various diseases. There are surgical trials looking at surgical treatments for heart failure, medical trials looking for medical advances in medical treatment. There are interventional cardiology trials looking at new valve treatments for disease. So it's really, honestly, an amazing time in the treatment of heart failure. And, you know, whether it's Dr. Brown, Dr. Vora, their colleagues in at Cardiology Associates, or in the Baltimore region, or here in the DC region, partnering with your cardiologist to identify what may be possible is really important. They're also really being able to understand, what is the disease I have? What type of heart failure do I have? That helps guide you towards possible clinical trial options. The final part I will say, which is exciting, is MedStar Health is a leader in clinical trials. This is an organization that has been a leader in cardiovascular care through the countless tireless efforts of countless individuals. So I think it's a great time to partner with your MedStar clinicians because there are a number of options.
Awesome, thank you. And Dr. Sheikh, one last question before we start to wrap up. I'll ask you, but Dr. Brown or Dr. Vora, if you want to chime in as well, go ahead. We have a question from Jackie, and she asked, I read an article where it stated that African-American women with heart failure are not treated as good as white women with heart failure. And she would like to know y'all's opinions on this.
Appreciate the question. We recognize throughout various aspects of the American life that we all live that disparities exist in the delivery of care across multiple ethnic minority groups. Unfortunately, currently, individuals of self-described African American or Black background are disproportionately affected by heart failure. They have a higher incidence and prevalence of the disease, likely related to disparities that exist in the social determinants of health. Inability to see physicians, uncontrolled hypertension, diabetes. And when we think about heart failure, this really rings true. Disparities do exist in the receipt of care for individuals of ethnic minority background. The exciting part is MedStar is a leader in this, and I can truly say that because we have the data to support it. In the past year, we were able to offer 48 transplants to individuals, making us a moderate to very large transplant program. 51 LVADs were received for individuals, and over half of those individuals were of an ethnic minority background. A very exciting thing, which makes us very unique, both in the region and in the country. The take-home message is empower yourself, advocate for yourself. If you are at risk, you have high blood pressure, diabetes, ask that question, am I at risk for heart failure? Do I have heart failure? And then work with your clinicians to be able to identify this. I'm positive within the MedStar health system, you will find a champion for yourself, an advocate who can help you. I'm positive that we can certainly deliver care to address those disparities. I'll turn it over to Jen or Tanya.
I think that was very well said.
Yes, I agree. I think it's just tough. Disparities do exist, and we're just doing our best to kind of counter that. But I think it's important to advocate for yourself as well.
That's a great message. Thank you. And thank you for your question. So one last wrap-up question. I know you guys are busy. Is there anything else important that you would like our audience to take away after watching this broadcast? I'll start with you, Dr. Sheikh.
I think I've perseverated on this topic. The goal for me to join today, beyond getting the word out in this month where we're thinking about heart health and Heart Failure Awareness Week is right upon us, is really the goal to empower patients and their family members to make sure they understand that this is a treatable disease. But yes, it requires education and advocacy on your part to make sure that you're doing what you can to prevent the disease and get the proper treatments. We are here to help, and there are countless other clinicians that are here to help. And again, function, not failure. Look at the advocacy groups. There's a lot of excitement, a lot of enthusiasm and optimism. This is treatable.
Thank you. Dr. Vora?
Yeah, I think just to add on to that, I think early detection and diagnosis is critical. And so listen to your body, be mindful of your symptoms, and don't wait. If you're worried, come see us. We're happy to help. And I think if we find it sooner, then we can help the trajectory get better.
Thank you. Dr. Brown?
I agree with what both my colleagues have said. And I would like to just end with the fact that this really is a disease that not only we can treat and treat well, but we can prevent. So I think it's important that we talk to our younger family members, even our children, about making sure our diets are heart healthy, that we're getting plenty of exercise, that we're doing everything we can to maintain good numbers. So our blood pressure is well controlled, our fasting sugars are well controlled, and our BMI is where it needs to be. These are all really important lifestyle changes that we should really focus on at an early stage. And the last note here is it's never too late to change your lifestyle. So if you have had uncontrolled high blood pressure, you've been overweight, you've not lived a heart healthy lifestyle, you've been a smoker, it's never too late to change your ways and help prevent progression of heart failure. And we're all here to help you do that.
Great. Thank you. Those are all great points to wrap up on. So thank you again to our viewers for joining us and asking your questions, and to our experts for answering our questions. If you would like to learn more about our heart failure program or make an appointment, you can visit our website, which we will be linking to in the comments below. Thank you again, and we will see you next time.
Thank you very much.
Thank
Bye.
you.